Assalamu alaikum, everybody. A very, very warm welcome to you. Good morning, good evening, wherever you are joining us from different parts of the world. We welcome you to today's session of the Population Health and Wellbeing series. I'm Dr. Suhaila Chima. I'm the Assistant Dean for the Institute for Population Health and also an Associate Professor of Clinical Population Health Sciences here at Weill Cornell Medicine in Qatar. Just to remind everybody, the objectives of this series are to discuss contemporary clinical topics which are relevant to healthcare, medicine, and population health. We examine evidence-based practices which are germane to public health and patient care. And we also look at describing opportunities and challenges in the evolving face of healthcare and population health. Just some housekeeping, your cameras and microphones have been turned off. We request that you please use the Q&A tab to type your questions and comments. However, if you just want to put them in the chat feature also, please go ahead and post them. We will be able to see them. Questions will be addressed at the end of the session, and I will be moderating the session today. As a reminder, this is an accredited activity, both by ACCME and also by the Continuing Professional Development CPD Department of Healthcare Professions Accreditation section here in Qatar. The post-activity evaluation, it should be available in your Cloud CME account by December the 1st. And you can go ahead and complete the evaluation, and then you'll be able to download the post-activity certificate once you complete the evaluation for us. So just as a reminder, basically healthcare practitioners which are licensed in Qatar, they will receive their credits once the QID, the Qatar ID and MOPH license number is provided. And this is, of course, following the circular from the Department of the Accreditation section of Healthcare Professions, Ministry of Public Health. So now today on to the speaker. So it gives me great honor to introduce our speaker for today. We are excited to have Zahra Babar with us today for the session. Zahra Babar is an Executive Director, Center for International and Regional Studies, Georgetown University in Qatar. She has published widely on areas related to research regarding her interest in migration. Some of them include the buying of freedom, migrant workers, and the Azad visa in the Gulf. Migrants from low-income countries have higher heat, health, risk profiles compared to native workers in agriculture in the Journal of Immigrant and Minority Health, the 2022 World Cup and Migrants' Rights in Qatar, Racialized Labor Hierarchies and the Influence of Racial Capitalism, with N. Vora in the Political Quarterly in 2022, and Qatar, the World Cup and the Global Campaign for Migrant Workers' Rights in Football and the Middle East, State Society, and the Beautiful Game. Her most recent book is a co-edited volume with Kyoko Matsukawa and Akiko Watanabe titled Transnational Generations in the Arab Gulf States and Beyond. Her today's title for the session is Social Determinants of Health Among Migrant Laborers in the Gulf, a Multidisciplinary Approach. Zahra Babar, a very, very warm welcome to you, and thank you so much for doing the session for today. Over to you.
Thank you so much, Dr. Chima. It is a true pleasure and privilege to be here. I'm so grateful to you, to Dr. Mamtani, and all your wonderful colleagues at the Institute. It is a privilege to be here, also to be engaging with your audience. I understand this is primarily healthcare practitioners and professionals from Qatar and the region. And it is always both fun and engaging for me to discuss areas of my research with colleagues who are perhaps outside my direct field. Dr. Chima has done a lovely introduction to my research, and I would just add to that by saying, as you've probably figured out, I myself am a social scientist. I have spent about years or so studying migration, and particularly over the last 15, 16 years, focusing on economic migrants in the 6 Arab monarchies of the Gulf. So my talk today is related to an area that is associated to my larger field, which is really looking at political and social questions around, migrant workers and migrant labor. But in relation to that, and within the years of studying this, I started to engage more in looking into other areas, particularly the one that I'm going to speak with you about today, which is on migrants' health vulnerabilities. I think I was meant to just disclose that I have no particular, yes, there it is, no financial relationships related to this research. So as is stated here on the slide, the goal today for me is to talk to you about migrant workers and health in the GCC, focusing specifically on social, economic, and structural factors, both which impact the vulnerability of migrants when it comes to health outcomes, and which also impact their capacity to access appropriate healthcare, to have their health needs met. I will be discussing labor policies, living conditions, and access to healthcare, and how these impact migrants' well-being in Qatar and in the rest of the GCC. I will conclude in the conversation later on some suggested areas of policy reform and gaps that have to be addressed, both in terms of policy, but also in terms of additional research that we need to undertake. Multidisciplinary research, which involves social scientists along with those who work specifically on health and medical needs. We'll move to the next slide. So my introduction slide is just to remind you that migrants and migrant workers are critical across the GCC states. From the 1950s and 60s onwards, when these 6 countries were really starting to engage deeply in economic development, because of the fact that all 6 of the GCC countries had fairly small populations, they started to rely heavily on foreigners who came to work across multiple sectors. This community plays a very essential role across the economy of these 6 countries, and a portion of this migrant population also faces significant health challenges. So I'm hoping that through the conversation I have with you today, I will be focusing both on why migrants should be studied, why they are particularly vulnerable, and what their limitations are when it comes to accessing adequate healthcare. By examining some of the barriers that exist, as well as understanding what makes migrants particularly vulnerable, we can hopefully identify critical areas for intervention. On the next slide. So my presentation and my talk will really focus on 4 particular areas. I'm going to begin by doing an overview. Really, the goal of this is to answer the question, why do we need to think about migrants specifically when it comes to health, both in terms of their vulnerability, as well as in terms of their access to healthcare? What makes migrants a unique community we need to be focusing on? I'm sure you, as health practitioners, might wonder, migrants are just part of, the population. What makes them special or different? And in order to address that question, I'm going to focus a little specifically on the demographics of the migrant community in the GCC. I'll follow that up in the second section of my talk by trying to help, talk with you about what the particular vulnerabilities are that migrants contend with, and what are some of the key factors that increase their vulnerability to poor health or poor health outcomes. I'll follow that up with discussing the barriers that prevent access to adequate healthcare for migrants, applying the same lens. I have used this distinction of 3 broad categories that I'll be focusing on, which are the social, economic, as well as systemic or structural obstacles and features. And then finally, I hope to conclude, solutions are always hard, especially for a social scientist. I spend most of my life just trying to understand complexities rather than coming up with solutions to them. But obviously, I have some ideas of what could at least help inform solutions, certain policy recommendations that could be undertaken. as well as I mentioned previously, identifying future areas of multidisciplinary research that could really help us in addressing some of the health vulnerabilities for the migrant population. So demography is a very important factor when considering migrants across the 6 GCC countries. Migrants, or every country is hosting different forms of temporary migrant workers around the world, pretty much. But the GCC states are a bit unique. As I mentioned, from the 1950s and in some cases even earlier, as these 6 countries started to explore their immense hydrocarbon wealth and started to invest deeply in development, they started to be increasingly reliant on bringing in foreign workers. So the demography of the GCC states is a little unique. Could I have the next? Yeah. So overall, the GCC is now considered the 3rd largest hub of global migration. Obviously, the other 2 hubs are North America and Europe. While the GCC states, in terms of the entire number of migrants present, is much less than those 2 other hubs, what makes it extremely relevant is actually the proportionality of migrants to citizens across the region. Now, before we focus on the demography, I have to say, as a researcher who works on migration, numbers are a big problem. We really struggle with coming up with a final proper number of how many migrants are present across the 6 countries in totality, as well as in each state. And there are constant discussions on what the final figure is. I will just say it is really hard to access a final number that everybody agrees on. So what we have here are estimates that have been collected, at least by organizations that use really evidence-based processes to try and get those numbers. At the very least, the most conservative estimate is that across these 6 countries, we have at the moment 31 million migrant workers. But the figure can go up to considerably higher than that, depending on who you look at. Saudi Arabia has the largest number of migrants actually present on its territory. However, out of the 6 countries, Qatar, the UAE, and Kuwait have proportionately the highest numbers of migrants present. Raji, could we see the next slide? Now, it is the percentages which makes the demography of this region extremely interesting, because you don't have any other part of the world where you have a citizen population that stands in minority against a foreign population, the way it's represented across the Gulf. The figures you're seeing here, in fact, I would say are conservative estimates. The actual population figure, for example, in Qatar, which says that 77% of the population is foreign. There are other figures that would have that as much higher, like closer to 90%. Regardless, these are the figures that I'm using from very official UN channels. This is also the entire population figure that is given as a percentage. What isn't given here is actually the workforce. So if you were to look at the Qatari workforce, the number of migrants percentage-wise in the workforce is closer to 90%, because the Qatari citizen population obviously includes children, people who are not engaged in the workforce, people who are the elderly. So the proportionality is even greater across these countries when it comes to just looking at the labor market as opposed to the overall population. So I think obviously the fact that there are just so many migrants present in the region means that we have to consider them as an extremely important population to consider pretty much in every domain, and certainly including when it comes to health, something as critical as health. We need to also understand that these numbers we have includes everybody. This includes foreign workers who are also white-collar workers, migrants who are working as physicians or health workers, or as professors at universities, school teachers. So that is the entire cohort. However, the largest number of migrants here fall into what we would consider low skill. I hate these terminologies. I think I don't like using them, but let's just say people who are engaged in work that is more physical in nature and that is, less well paid. I'll have the next slide. So, for example, almost 6 million migrants across the region are working in the domestic sector. This is a sector which has increasingly demonstrated particular vulnerabilities, including health vulnerabilities for those men and women who occupy these positions. Another sector, which of course you'd all be familiar with, would be the construction sector. Across the region, I'll have the next slide, Raji. Across the region, we have, again, a very high number of migrants who are working in construction, and the majority of these are male workers. In addition to the construction and domestic work, that most migrants are working in sort of transport, retail, largely sectors which are low paid comparatively, and which also end up shaping their capacity to sort of access their healthcare. So I'll have the next slide. Now, we know that migrant workers are essential to the GCC's economic development and growth. They play critical roles. We know how essential they are because there is a limited amount of local labor, particularly so again when it comes to Qatar, Kuwait, and the UAE. Saudi Arabia and Oman and Bahrain are a little more diverse, as their citizen populations tend to occupy a lot more jobs in the labor market. But in these three countries in particular, migrants, regardless of these are not highly paid or highly skilled workers, but they play an incredibly essential role. The demographic and economic dependence that the Gulf states have on this cohort of their workforce means that ensuring that they are healthy and have heightened well-being is essential. Otherwise, there would be economic and development implications to that. In addition, the other reason why it has been increasingly important. Sorry, Raji, could we have the next slide? So why it is, in addition to the fact that we know this cohort is extremely large, it makes up a substantial portion of the population, and thus it of course becomes essential to think about them when it comes to their health needs and health vulnerabilities. There's also been increasing scrutiny of all 6 GCC states over the last number of years. Many of you would be aware of the dedicated campaign that focused attention on Qatar after it was awarded the bid to host the 2022 World Cup in football. Increasingly, international organizations, United Nations agencies, other international governments have been looking very closely at the GCC states and scrutinizing how they are treating and looking after their migrant worker population. And amongst the various concerns that were raised during some of the conversations in Qatar, in addition to conversations around labor rights abuses, the lack of adequate wages, there was a lot of discussion around health risks and migrants' exposure to health vulnerabilities. So it has become an issue that the GCC states, at a government level, have had to address and take quite seriously. These countries all engage as part of the international order. They have to maintain a certain reputation and standing internationally. And taking care or being responsible for the health of the migrant worker population is an essential part of, for the GCC states in terms of their international engagement. Another thing that is extremely important to remember is this part of the world plays a critical role in the global economy when it comes to hydrocarbons. The Gulf states are very much situated as a critical member of the global political economy. And being a region which produces a very large amount of global energy sources, this is an essential sector that needs to be able to carry on with its work so that those energy resources are available to the world. We don't talk very much about the migrant worker population specifically in relation to the hydrocarbon industry, but it is implicitly understood that in order to have a stable global energy system, we need to have a healthy workforce in the Gulf that's working in that sector. Finally, of course, we have COVID in our not too distant memory. And I think what the pandemic highlighted, not just in GCC, but globally, was that migrant workers are a community of intense public health concern. This was an issue which came to attention in multiple parts of the world which rely on migrant workers, and where migrant workers contend with similar living conditions and social arrangements. And so again, the fact is that the health of the migrant community is important for public health reasons across the GCC as it is elsewhere. The next slide. There are a number of reasons for why we consider migrants to be at particular risk when it comes to health vulnerabilities. I think the thing I'm going to start off with is what would apply to migrants anywhere in the world. And this would be not just necessarily lower income migrants, but also, migrants of every category working in whatever sector. When you are not on your home territory, when you are not at home where you enjoy citizenship, where you enjoy your social networks, where you enjoy your resources, your social capital, you are immediately in a position of a degree of vulnerability as a foreigner. That's like a basic thing. And that's globally understood, that we have to be attentive to the fact that your status, your immigration status, impacts you in multiple ways and makes you a person of vulnerability. But there are the previous one. There are three particular things that I'm going to be focused on in my comments here, both in terms of why migrant workers in the GCC are particularly vulnerable. And then later on, I'll be using the same kind of categorization of the social, economic, systemic / structural when we talk about migrant workers and access to healthcare in the GCC. When it comes to social factors, this is really social factors for lower income or low skilled workers. There's a positionality of migrant workers within Gulf societies, which determines a number of ways in which they experience life here, and which makes them vulnerable to a range of different issues, including to vulnerability when it comes to poor health outcomes. Migrants tend to, first of all, they occupy lower socioeconomic positions, which influence their access to resources and opportunities. So what is also really important to consider is what we call intersectional factors, right? So it's not just that these are lower income migrants who are earning lower wages and who have fewer financial resources. Factors such as nationality, their country of origin, their ethnicity, their race and gender, and their age will all impact their experiences while they are in the Gulf, living and working in the Gulf, and will also impact their health outcomes. Many lower income migrants, low wage migrants, as you know, live in overcrowded accommodation. They have poor quality housing. They're frequently 6 people sharing a room. This has multiple, consequences, but of course it also means that they face a greater risk of exposure to disease transmission. They tend to also be more isolated socially. Many migrant workers are assigned to a job site. They leave their employer provided accommodation. They will go to their job sites. They will return at the end of the workday. They do not have many opportunities to build social networks, to build friend circles. Most of the people they would be their co-workers, their employers, their supervisors. That lack of social support for many migrants and contending with separation from family, separation from friends, poses lots of, forms a lot of source of stress for them, anxiety for them. It also means that heightened risk of depression, of mental health, and these issues as well. And then, of course, migrants come from so many different parts of the world to work in the GCC. While some of them might be well able to communicate in English or in Arabic and cope with communication, they have fewer communication challenges. Many of them face communication challenges. And it's not just the actual language skills, but there are also cultural barriers. And again, I'm assuming many of you who are working here in Qatar or the Gulf would be seeing this with when you're working with or dealing with patients. Different societies have different cultural approaches towards healthcare. They have different social and cultural sensitivities around privacy and what to disclose. And this all has an impact on migrants' ability to really have to discuss their health and to have their health needs met. We'll have the next slide, please. Economic factors, I think, are easy to understand. This is something that we would all assume. I mean, we know that people who have less money and lower wages are probably able to not afford many things in life, including affording the best healthcare. But in addition to issues around the lack of the money to invest in your health, it means you have less money to, for example, invest in things like a healthy diet or to invest in like a healthy lifestyle. You don't have the time to engage in activities which are good for you, which promote ways in which you can address your stress and anxiety. You're less likely to have time to engage in recreational activities. And an additional thing that I do want to mention here is that many of the migrants who come here and occupy these lower sort of strata jobs or manual labor, blue collar jobs, arrive in the Gulf already in a situation of financial precarity. Many of them have taken on debt in order to finance their migration journey. While the Gulf governments have quite strict rules and insist that employers who are bringing foreign workers here should bear all the costs, like the costs of travel, the costs of visa, and anything else associated with coming to work in the Gulf. What our research, a lot of research demonstrates is despite those rules and regulations, most migrants take on some form of debt to pay recruiters to get jobs in the Gulf. So several of them are many of them are already arriving here with that additional stress of knowing that they have to pay back these debts. And that places them in a situation where if they are to make choices on what to spend their money on, it is highly unlikely that they are going to choose to spend their wages or spend their money on things that would enhance their well-being or their health. They are far more likely to send all of their money home. The next slide. So the systemic and structural features, this is probably where a lot of my work has been over the last years, because I study governance. I look at it from the political and policy perspective. So the systemic factors that exist and have an impact on lower income migrants, they're manifold. There's so many of them, but I'm just going to focus here on a couple which are specific. So across the GCC, there are restrictive immigration and labor policies. You would all be familiar, I'm sure, with the kafala or sponsorship system. Even though this system has been reformed, there have been some really positive reforms to this in Qatar and in several of the other GCC states. Many migrants are now more easily able to change jobs or switch to new employers if they're unhappy with their current job. Despite these reforms, though, mostly the migrants are still tied to an employer and a place of work. Many migrants get these jobs, obviously, while they're in their country of origin. They sign on to these contracts. They invest their time and money and resources to get those jobs. And once they arrive in the GCC states to take up employment, even if they are contending with situations that are challenging, such as they're not happy with their wages, they're not happy with their living conditions, they're not happy with the treatment they're receiving, or even perhaps the nature of the work they're doing, they would be reluctant to change jobs. Being limited in terms of how easily they can transfer their skills through the labor market means that they're frequently willing to contend with quite difficult situations. This can certainly have an impact on their health and well-being. There is also a general, sorry, I'm going to stay on that one for a bit. There is also just the reality of the work itself. There are many jobs which are just physically more taxing, certainly more physically demanding than mine. A lot of the work that lower income migrants are doing is they're engaging in outdoor work, if they're working in construction, if they're working in transport. Their work demands that they put up with extreme physical difficulty. In Qatar and the Gulf, this would frequently be the heat. Heat stress is a major issue that leads to a lot of migrants seeking emergency care in hospitals across the region. There's been a lot of criticism towards employers in the Gulf states for not providing migrants with adequate protections when they're working in these sectors. And then, of course, there is also the fact that migrant workers, again, because of their positionality, because of their country of origin, because of their low social status, they may not be prioritized when it comes to the healthcare system. They may also find themselves contending with forms of bias and substandard treatment when they actually access health facilities. I'll do the next slide. So what I want to do is just pause here for a couple of moments to talk about two things. I think it's extremely important, and I've thought in my research at least, to know what I don't know and to remember what it is, to remember that I don't know some things and certain things. I have just highlighted and discussed with you some of the factors that influence migrant workers contending with, being more vulnerable to health risks and health challenges. But the fact remains that when it comes to broad-based evidence work that has gone into this, there are some challenges. One of those challenges, when it comes to the GCC states, I do a lot of comparative research. I did a project, for example, with some colleagues on agricultural workers in Cyprus. Now, when you're trying to come up with a strong case that says these migrants are suffering certain conditions in their workplace, which exposes them to, health risks, and they are suffering these risks because of their status as migrants, the normal way you would prove this case is by actually studying a group of workers who are engaged in the same work, and a cohort of those are migrants, and another cohort are not migrants. So like the study we conducted in Cyprus, we looked at agricultural workers, some of whom were migrant workers who were working in Cyprus on these farms, but another cohort of them were actually Cypriot citizens who were engaged in the exact same labor. That's a very interesting study. I'll talk about at some other point, but we were able to prove conclusively in that study that the migrant workers were ending up with higher markers of heat stress and heat stress related illnesses. And my role in that project as a social scientist was to try and figure out why, because they were doing the exact same kind of work, both the citizens as well as the migrants. They had the same wages, they had the same work hours. But what we were able to determine is the difference was that the migrant workers engaged in that farm work, they took shorter breaks. Even though they were mandated to take the same amount of breaks, the migrant workers would rush through their break. They were meant to have like a 20-minute break. They'd be done in 11 minutes and get back to work. The migrants and the citizens were tasked with the same thing. For example, one of them was they were carrying these heavy crates full of produce, right? In the same time that a citizen would carry, say, 2 crates, the migrant was carrying 3 or 4. Because again, as a migrant worker, they were more concerned about performance and how their supervisor would view them. They were more concerned about being considered lazy or not working hard enough. And as a result, they worked much harder because of how vulnerable they felt and how concerned they were about losing their job and having to go back to like Bangladesh or Nepal or whichever. I'm bringing this up as an example because similar work is very hard to do in Qatar. in the construction sector or in the transport sector or in the domestic work sector, if we were to do an evidence-based study, it would be really hard for us to find, impossible, frankly, to find Qatari citizens engaging in the same exact form of employment and the same kind of work as the migrant. This is a problem. This is something we need to find a way to address if we want to be able to give more evidence to some of these arguments we're making about why migrants are more vulnerable. A second, what we don't know and need to know is that this community, the migrant worker community, is a hard one to study when it comes to health, along with other things. But why I focus on health? The health of a human being doesn't deteriorate necessarily all in one moment, right? We know that, yes, we know that migrant workers in construction face like fall injuries or heat stress related illnesses. But what research in Qatar, for example, has showed is that a lot of migrant workers here are at risk for cardiovascular and pulmonary issues, right? And that many of the cases of migrants who are being hospitalized for those conditions. Now, can we say with certainty that the reason they're showing these cardiovascular illnesses is because of the work they are doing in Qatar? Well, we can only say that if we actually have longitudinal studies, longer studies, which track the cycle of migration, starting in the country of origin from which a migrant comes, to see and to do an intensive amount of work to actually see what their health status was there when they were stable and at home and before they became a migrant. Then continue to track their health once they are actually located in the GCC country and working here. And then follow that on with a study of the same migrant once they return at home, so that you actually have a period of time in which you can assess whether the duration of working in the Gulf actually very negatively impacted their health. We don't have those studies, and that also means that it's quite problematic. I'm sorry for this long sidebar, but I think it is really important to keep these things in mind. We'll move now to the next slide. So in this section, I'm going to talk using the same format of sort of looking at the economic, social, and structural. We're just going to go through some of the barriers that actually prevent migrants from accessing healthcare in the GCC states. We'll have the next slide. So again, as I mentioned, I'm going to spend some time again talking through what some of the social barriers are, some of the economic challenges, as well as some of the systemic ones. And you'll see that many of these overlap with the same factors that actually lead to migrants being quite vulnerable to poor health outcomes. Next. So again, the social barriers, what we know from migrants is that there's a limited awareness of health information. Many migrants, before they leave their country of departure, whether they're coming from India, Nepal, the Philippines, a lot of those sending states have invested in trying to educate migrants in what they call pre-departure trainings. They tend to speak to them about what they can expect when they live in the Gulf, what the social setting is like, what their economic circumstances will be like, so that they come with eyes wide open. The problem is really that there's a lack of an integrated sort of education around health when it comes to those pre-departure trainings in these sending countries. I've attended several of those trainings myself over the years. The problem, one of the quandaries for me, is that when it comes to health, early on in a migrant worker's journey to the Gulf, one of the first things they actually have to do before they're anywhere close to getting a visa or a job contract is they have to go through fairly rigorous sets of health tests. And this is a quandary because for migrants, in order to be able to move forward in the process of getting a job, to live and work in the GCC, they have to demonstrate that they have good health. They have to demonstrate that they have no communicable diseases. They have to demonstrate that they don't have TB, that they don't have any like weakness of the lungs. And that process of going through those health checks is quite stressful for migrants. So many of them have invested so much emotionally in this idea of coming here and getting a job and making a success of themselves, earning better, providing for their families. When they are going through those health checks, it leaves them with this sense of intense stress and vulnerability, and the idea that they need to be in good health. They need to demonstrate that they are healthy, and healthy workers are what the Gulf needs. At a very early stage of the migration process, this means that it becomes fixed in the migrants that when it comes to health, what they need to be concerned about is consistently demonstrating that they are in good health. This has long-term lingering impacts on how they deal with their health issues once they're in the Gulf, and it impacts their ability to be open and forthcoming when they're actually having health issues. Again, the migrants tend to be employed, as we've already discussed, in lower skill jobs. They have limited opportunities to work in jobs which aren't as physically stressful or as dangerous. And this again means that they are less likely to be able to move into a job where they're not working outdoors, where they're not working in physically arduous circumstances. And then again, as previously discussed, migrants' social position in society impacts their ability to access resources, which includes their ability to access resources to be able to, access appropriate healthcare. So the lack of health education, the kind of suspicion and fear when it comes to health authorities. Now, remember, because the early stages, their encounters with health were all about like testing. And so there can be this reluctance to engage with health professionals because they see health professionals as like scrutinizing them rather than offering to help them and develop their well-being. And then lack of resources, lack of proper social networks, all inhibits and acts as a barrier when it comes to migrants seeking appropriate access to healthcare in the Gulf. And the next slide. The economic barriers, I'm focusing on a couple. And one of the things that consistently, I've had many conversations with physicians, colleagues I've worked with on joint projects. We frequently speak about the fact that we know that the actual structure of healthcare in Qatar, in the GCC states, tends to be like often much better than the structures and systems of healthcare that migrants are able to access in their home countries. So if that is the case, if we know that the GCC states have invested so much in very high level of high quality medical care, then why are there these barriers? I mean, migrants here are provided state delivered public health care. And so they should certainly have greater access to it. And by the way, the question on that is not definitive. The answer to that is not definitive. Again, research is needed. But some of the issues when it comes to the economic ones is that migrants do not, even 10 riyals is a lot for many migrants. So if they have to do a copay for like medical costs, for medical treatment, if they have to do some sort of investment in paying for like medicines, even amounts that seem very negligible and small to many of us are a huge burden on them, and migrants will forego spending that. So there are certainly still insurance gaps. There needs to be a greater attention given to how to ensure that the migrants who are in certain sectors in the economy don't fall through the cracks and don't have to continue to pay these, out-of-pocket expenses. And mostly, while we know there are very good both public healthcare and insurance schemes across the Gulf, it is still a place where healthcare costs are high. And for lower income migrants, they are certainly high. Now the next slide. So the systemic barriers that when it comes to actually accessing healthcare, some of these I have addressed. Migrants fear, again, the sort of legal and administrative hurdles they have to meet or cross in order to access healthcare. So if they need to navigate their supervisors and the bureaucracy of their employer in order to seek healthcare, in order to get time off to go and see a doctor, there's often a fear around like filling in those forms, asking for time off, even trying to determine where they should go, which kind of hospital or clinic they have access to. a lot of times they will avoid even seeking medical care because of their fear and lack of understanding of what they need to do, how they need to get the time, not just the time off, but how they need to actually manage the administration of these systems. Employers need to address this by much more actively informing their employees, their sponsored workers, of what is available to them, to make sure that there are no penalties, that there are no salaries docked for seeking medical health care. But I mean, these are complaints I have heard very regularly. As sponsored workers, migrants are really highly dependent on their employer's permission to be able to seek medical care. Frequently, it's not even about just getting a sick day, but it's like, who's going to cover my transport costs? How am I going to pay to get to the hospital? Many migrants might be living in locations which are far away from any of the facilities that are specifically dedicated to them. And so there are these restrictions on being able to adequately seek care that they need, which are tied to their sponsorship arrangement. At a broader level, one of the systemic features of the healthcare system geared towards migrant workers in the Gulf is that typically a lot of the care they receive is provided like at an emergency or crisis level. There are fewer systems or policies in place which allow migrants to have ongoing access to, or even sort of preventative treatment. Here, next slide. So again, when it comes to the overall argument from those of us who work broadly on the governance and regulation side of, when it comes to migrants and healthcare, what the argument that is frequently we make is that it's not about a lack of medical facilities available. It's not about a lack of financial resources from the Gulf states to invest in proper appropriate medical care for migrants. And it's not about ensuring that the physical architecture of the healthcare system is there to meet their needs. It is really about migrants' positionality and how they are structured socially and economically into the country, which impacts both their health risks as well as their access to adequate health care. I just spent a little time. I don't know how, oh my God, I think I'm completely run out of time. Okay, like 3 minutes. There have obviously been steps that have been taken, and work has already been undertaken across the GCC states in terms of moving this forward. There is broad recognition and understanding that ensuring that migrant workers are in good health and have access to good healthcare is important. So we have a few cases I'm going to go through just, I think, very briefly to give you some insights on what we have seen, particularly in Qatar. I might focus on that and post in the run-up to the World Cup and after that. Could we have the next slide, Rajiv? Right. So the case study one, have I missed that? Yeah, so this one. So as you know, across the region, the Gulf is now increasingly known for hosting so many mega events. These countries have some of these very large global cities which have invested in multiple sports events and other events. And of course, in Qatar, when it was awarded the World Cup, so much attention focused on the conditions of migrant workers. And there was a lot of concern and discussion on the particular rates of injury and dehydration, heat stress for workers who are specifically working on stadium projects. Qatar engaged in an extensive series of reforms from 2017 onwards, and these culminated in some really landmark decisions, such as ensuring a minimum wage was in place for all workers. Sponsorship arrangements changed to the extent that migrants are now more easily able to change sponsors. So if the point being that it forces employers to treat their workers better, pay them better, otherwise they risk losing them to another job. And there were also a focused set of interventions and policy reforms to try and address housing and living conditions, to try and address injuries and occupational safety at the workplace. And so it has been just a few years. So we need to engage in some ongoing research to see what the impact has been of these reforms when it comes to healthcare in Qatar for workers. They have instituted changes to the kinds of breaks that are mandated on work sites, ensuring that migrants are not working during high heat hours. But of course, it is still a challenge to ensure that these are enforced, that these policies, while they are in place, that employers are actually abiding by them. There is such a massive workforce of migrants across the country, which is replicated again in the UAE and in Saudi Arabia, that it is not that easy for the state to ensure compliance, and there are ongoing efforts to make sure that those continue. I have a couple other cases here, but they are basically just to provide a comparative framework and just to demonstrate for you how across the GCC countries are engaging. I mean, they have recognized that this is an important issue. They have also understood that it is a multidimensional issue. It's not just about providing better hospitals, more doctors, those sorts of things. It's about really looking very specifically at the factors that impact migrant workers and to try and address those through like multidimensional policies. I think I will proceed to wrap up because I do want to hear from you all. I would just say that it is really important to remember that the health risks and vulnerabilities for migrant workers, as well as the barriers to healthcare, are multidimensional. They cannot be fixed solely by healthcare providers. They require a multidimensional and multi-stakeholder response when it comes to thinking how best to ensure migrant workers' well-being. We need to have sending countries' governments involved. We need to have receiving states here in the Gulf ensuring that they're doing the best in terms of policy. We also need healthcare providers. We need migrants to be part of this conversation. There are also existing research gaps. We really need to find better ways of providing the evidence, so that will help determine if we have the adequate evidence that demonstrates that it is migrant status that is impacting so many of their health concerns. We can only do that through these comparative studies as well as longitudinal studies, which recognize that the migration journey begins at home and ends at home. And so migrants' health needs to also be tracked along those lines. I'm sorry I've taken so much time. I hope I haven't bored you all, and I will look forward to hearing from you.
So, Zahra, thank you so much. It was a wonderful session, very comprehensive. So, thank you so much for giving us all that information and looking, from a close lens with all the issues that, migrants may be facing in GCC countries. And congratulations to you on all the work that you've done in the GCC on this issue, because obviously it's a very, very important issue here in the Gulf. As you rightly said, there's a large population of migrant workers living here. Thank you so much, Zahra Babar, for this wonderful
Thank
session.
You so much.
We're really grateful that you could take time out from your very busy schedule. And we are also very grateful to all our attendees.